right now there is still so much emphasis on the disease modifying trials. And what we have learned over more than 25 years of working in this trial setting is that disease modifying trials are useful when you find people in the earliest prodromal stages of disease. And if you start treating at that particular time, yes, you can remove beta amyloid. You can clear it out beautifully. You can clear out beta amyloid beautifully in any stage of the disease. But when you do it at the earliest stages, as not so much the Biogen work, but Eisai's work with Leqembi, which was just impeccably done, beautifully executed. This is like the creme de la creme of a piece of work. And people should take a look at the quality of that and understand they did everything right. Still, when you examine it, you see, okay, there is a benefit. Yes, they are slowing disease progression, most definitely slowing disease progression. It looks like they're slowing it down by about 6 months in that cohort of patients. So I always preface it with things like in that cohort of patients with very, very early stage disease. We also know after many years that if you were to pick up those same patients at a later stage of disease, at the mild to moderate stage, and do the exact same treatment, you would be unlikely to see the same benefit because their disease has already manifested for a little bit too long. So this is an early intervention. It's an early intervention that is useful if you live around a place with an academic treatment center that has very sophisticated PET scanning equipment, and if you are around an area where people are going to notice things about your condition very, very early and get you to that university medical center for evaluation. So how do I link that into the diversity in trials? That doesn't describe the majority of people who have Alzheimer's disease. And so this is where we run into these problems about the best plans, the best intentions that we possibly have, still don't often help us get around our, I don't want to call them prejudices because they're not, but our general way of thinking and looking at academic centers primarily as being one of the big ways that one finds patients with dementia. And also we want to find patients at later stages because they can benefit from symptom management drugs, like our drug, which is still in development, like Aricept that's already on the market, like Namenda that's already on the market. And so there are other things that we can do, other interventions of just keeping patients busy, socialized, active, things to do. Those don't happen so much in academic treatment centers with elaborate PET scanning devices that can tell you, how many femtoliters of protein that you can have. That may or may not even be useful because we know from the data that patients can go to the grave with massive plaque and tangle load, but be functionally quite with it and not have Alzheimer's disease at all. Other patients have a very modest plaque and tangle load and frank Alzheimer's. So we're talking about all of this approach, which I would not want to denigrate one single bit. It's all good. We learn from everything, really only addresses a certain facet of patients. How do you go to mainstream patients that are going to be seen by a family practice physician, by perhaps no physician? And these are the patients where you want to target symptom management treatments like ours, like donepezil, like others. And so that means finding other ways to reach them. And this is where we're lacking because especially if they're rural, just getting them into a doctor's office is difficult. So if people want to assign diagnostic criteria that require a certain amount of I don't want to say fancy work, but that's certainly how those patients would describe it. We're going to miss them. And the basic diagnosis that has been used by NINCDS criteria for years is not fancy work. It's digging work, digging into the symptoms, digging into really talking about the patient's life and how they're functioning that any physician can do. if they're trained to do it. So I'd say more mainstream physicians being trained in how to not recognize Alzheimer's disease in a quick 5-minute interview, but actually taking the time to do a good mental assessment every few years with the patient to sort of dig into those things, have a conversation with the person who is providing their care for them to learn a little bit more about how they're functioning in the home. And those are the things that require time, they require effort. It's not just something that you can say, buy a blood test off the shelf and say, let's do this because this will give me the answer I need. Yeah, that works for diabetes. Taking blood pressure works for hypertension. With Alzheimer's, again, we're talking about another layer of complexity. So if we want to go after the diversity in our patient population, we have to go to them in the way that we approach diagnosis. And that doesn't require any changes. It doesn't require the development of any blood tests. It doesn't require any PET scanning. What it requires is a basic general and thorough assessment. And when you see cognitive deficits, ruling out treatable causes like B12 deficiencies, sexually transmitted diseases, stroke, other types of things, which can be ruled out in very less sophisticated ways.